just apply the wheat hair removal cream, which cost you just some 50 rupees, and that will last for 2 months. हाँ? थोड़ा इधर लेके आएंगे था. So here it's a cadaver, so yes, better. इस ऊपर वाला लाइट चला जाएगा? नहीं, लाइट बंद करें, क्योंकि वो लाइट और थोड़ा चलो. हाँ, यहाँ बेटर. So look at the beauty of the endoscope camera and panoramic view. This is what the panoramic. Now what you will be doing, I will be standing behind you when you will doing the microscopic. Try looking into the microscope and then compare it with. So first, anatomy. Get oriented to the endoscopic anatomy. I typically operate with like as a microscope. This is left here. If you see completely the tragus, incisura terminalis, concha, this is antitragus, in between this is incisura terminalis. That is my area for end oral incision. All my operations are transcanal. I harvest the tragal cartilage from here and then go by the transcanal approach. When there is an cholesteatomas, extensive cholesteatomas, I take an end oral incision, I harvest the tragal cartilage from here and then carry out the whole of the work. So I will be demonstrating you this approach, and typically what you do with the microscope is a post-oral approach. So you can see this after extracting the pinna. This is a retroauricular groove. So just a 5 mm from here, you can take the incision. For you, there will be the dry bones. It may not be there, but these are the typical approaches what you will be doing for your patients. Okay? So, is this clear?
Sir, so, these surgeries are done under local anesthesia, or you prefer general anesthesia for endoscopic ear surgeries?
I am not able to hear.
The surgeries are done under local anesthesia or general anesthesia?
I'm sorry, I can't hear you properly.
Sir, the surgeries are done under local anesthesia or general anesthesia? Local or GA?
Okay, got it. So I have a private hospital and I almost everything do under general anesthesia, because nowadays the anesthesia is so wonderful. My anesthetist give me 90/60 blood pressure. Well, let it be a tympanoplasty, let it be a mastoid surgery, let it be a stapes surgery, and the pulse rate below the 80. This is a combination where this completely nice bloodless field is there and you can carry out your work. So I do all operations under general anesthesia, and even being a private practitioner, my patient demands that he do it under general. So we are doing under general anesthesia completely. So typical graft for me is a tragal cartilage, because I do each and everything with the cartilage, but I slice the cartilage for doing the thing. So this is the tool. I hope, are you able to see this?
Yes, we can see that.
Yeah, this is the tool with which I slice the cartilage. Okay, this is not just for the slicing. If you can see, there are things to measure. You can see there are the things to measure your prosthesis, like a stapes prosthesis, your titanium torp and port. And if you can see on this, you can create a wonderful graft on this for the shield graft or the slice shield graft. Okay, so this is a slicer, so called as a slice it. So it's not only for the but for multiple tool for the otological work. So let's go and do first the endoscopy here. So this is tragus. So I will typically go is first do the endoscopy. Get oriented. Now I am keeping my endoscope just 1 centimeter outside the external auditory canal. External auditory canal is a canal of 7 to 8 millimeter, having the length of 36 millimeter, inside 24, outside 12. Okay, so this is a cartilaginous part, this is a bony part. Note the beauty of panorama. So everything is in front of you. You are not going to miss anything. Okay, so this is an anterior wall of left ear, this is a posterior wall, this is superior wall, this is inferior wall. So with the typical approach, you can see the eardrum here. This is a cadaver which is formalized, so you will not typically see the fresh cadavers experience, but I can demonstrate many things. So it's good, nice ear canal. So let's go ahead. Clean. So once you are here, we are doing the endoscopy. This is a 4 millimeter endoscope. Is the picture good there? Hello? Ball point, right?
Hello, yes sir.
Yes, picture is good there?
Yes, very good.
So anterior wall, posterior wall, superior wall, inferior wall. Anteriorly you can see some overhang here. Then there is inferiorly there is overhang. Can you see the eardrum?
Yes,
so this is the eardrum. So divide it into the 4 quadrant: antero-superior, antero-inferior, posterior-inferior, posterior-superior. Okay? Let's go a little bit near. So why the endoscope holder needs to be a dynamic one? So you can go easily. Look at this. You have to just go like this. Now this is a 4 millimeter endoscope and this cadaver is a stiff one. So I am having little bit of difficulty, but still no problem. We will chop up the ear later on and we'll carry out the dissection. But I will demonstrate before that how to harvest the cartilage and all. Just for the anatomy purpose, this you might not see with your dry cadaver. Chota section. Can you see my 2 hands?
Yeah, we can see.
See this. So this is how you carry out, okay? So what I can see, this is a Sharpnell's membrane. This is a handle of malleus here, lateral process, okay? So we will be elevating that. Let's go a little bit near. Look at the beauty of the endoscope. Can you appreciate?
Yes.
Yes.
Very well.
So this is typically a panoramic view. Even if the overhang is there, still you are able to see the anterior part, that's antero-superior, antero-inferior part. Okay? Coming out again, this is the way you can just cruise through the ear. Look at this. I came out. I am going in. Go as near as possible. Come.
It's like zooming in and out.
Yes, exactly. And now you can carry out the things. That is what the beauty of the endoscope holder. Not just as a static. Please make difference. This is totally different endoscope holder, and this has got the US patent now. And this will become a motorized in some days. So just, I hope I will convert Farooq to the endoscopic ear surgery. So just imagine the Farooq is pressing on the left hand and the endoscope is coming out. If it is pressing left, it will going smoothly in. So that will be the feature for the everything, not for the ear, for the nose and the yes. So this is how you can carry out the thing. So let's come out. So we will first harvest. Just clean. मेरे को एक infiltration के लिए का एक 2 ml or anything, or even I will show you the infiltration, because these basic things has to be learned. Okay, it may not be there how we infiltrate, because infiltration is also very important. I infiltrate that tragus and then all canal.
So what is the strength of the solution? Like it's a ready-made or?
It is a ready-made xylocaine 2% with adrenaline, 1 in 2 lakh. Because I operate under general anesthesia, so that's why I don't need that much of adrenaline. And then you can use a topical also in between.
Like another way of making local anesthesia is we can make 10, 10 and 10. 10 ml of normal saline, 10 ml of plain xylocaine and 10 drops of adrenaline. That also gives us a very good field.
Yes, I agree with that. So I will just showing how to do the, just I will be, अरे काय clean बरोबर. Strikers next on. So first, cameraman, नहीं कैमरे का पिक्चर थोड़ा सा किधर है, स्टोरेज वाला किधर?
We can see it through the endoscope, sir. Go
नहीं,
ahead.
you can see, but that picture is not good. So camera some problem. क्या ऑटो मोड पे चला गया है क्या, वो क्या है? This is clean. It's fogging. It's fogging actually. This fogging है वो ना?
No, it's clear now.
Yeah, no, that's getting fogged. This is due to the formalin fumes.
So in live situation, for defogging, do you use this Savlon or normal saline?
We use a Savlon. मोटा दे रहे, suction चालू नहीं है. Suction कारण हे मध्ये मध्ये राहणार आहे, कारण हा याच्यात पाणी येते का, मला पाणी घे बघू याच्यात. पावर बार, हाँ थोड़ा पाइप चेंज करेंगे. हाँ हार्ड है और ये इधर किंक हो रहा है. हाँ so let's go because that's an fogging. So first the traggle, I am just using normal saline here, so just to show how to do. Then in incisura terminalis, okay, look at this, and then on the medial side, let's go near. This is for the harvesting the cartilage, okay? Right. And then posterior canal. Just I am showing you the point because this is a hard cadaver, but to know where to do. And then inferior wall, can you see that? Look at this. And then superior wall, okay, and then anterior wall. Take a time for these steps, and then you will get that good field during the surgery, and you will not perspirate why the field is not good. And I will show you the posterior also. Just isko पकड़ा. So I will keep here, and then one go you have to do. This is a post-auricular. So first, and then go in through the same down, and then come through that. We harvest the temporalis fascia from the end oral only, okay, and then going from here, leave it, choda. Go from here.
Taking temporalis fascia as well, or only the tragal cartilage?
Come again?
You'll be taking temporalis fascia for grafting, or only the tragal cartilage?
There's a lot of echo.
Only tragal cartilage, or along with that?
Yes. So majority of the work is done with the tragal cartilage, clean. And whenever there is a secondary, means revision surgeries, second revision, third revision surgeries, and we want to close the mastoid, and we have developed that concept of neomastoid creation. So for that, then we harvest the conchal cartilage and we take a fascia lata, okay? Because we don't create a cavity nowadays, so we create a neomastoid. So let's go to show you the how to harvest the tragal cartilage. Thumb forceps, 15 number blade. Preserve the 5 millimeter outside, very important for the cosmesis. Can you see that?
Yes,
so
yes.
You just hold like this, 15 number blade. from incisura terminalis to just through and through. Go through and the cartilage should be delivered. Harvest as much as cartilage as possible. Just 2 stitch is needed here of 5O vicryl. That's all. And your patient will be happy, not seeing any scar, nothing. Can you see that?
Yes, yes, we can see it very well.
Look at this. This is a perichondrium on this side, perichondrium on that side. This is a cartilage, okay? So many of the time, still our army doesn't accept the cartilage. So I harvest only the perichondrium and I do the tympanoplasties, okay? So now dissecting these. If you don't understand, please tell me, because this is an endoscopic picture.
So we'll take out the whole cartilage with perichondrium or only the perichondrium?
No, whenever, only for the army people I take a perichondrium, otherwise the whole cartilage, because I use a slice cartilage of 0.5 mm thickness. See this, I am just dissecting this. For the sake of demonstration, I will harvest as much big as possible. This is a formalized cadaver, so
Live
bit.
situation, it's very easy to elevate this plaque.
Just I am dissecting. Many of the times some small defect is there. You can reach up to the bony and cartilaginous junction of the EAC. Look at that.
So delegates, if you want, you can ask directly questions to sir, or you can pass it to me. I'll ask and put for sir.
Come again.
No, I am telling that if somebody wants to ask anything, they can ask directly or they can share through me.
Yes, you can just moderate and ask me the question. No problem. They can ask you, because there is a lot of echoing. Okay, can you see that? Now I completely dissected, and now dissection for this. Just go inside, go and dissect. You can cut, hold the cartilage. Look at this. Note the beauty. This beauty of endoscope and the high good camera, HD camera. If somebody gets a wet bone, then you can practice this. Very important, believe me. Even if you are using the temporalis
Better now?
If you are using the temporalis fascia or any other graft, but for the cartilages will be needed for the atticoantrostomy to close that, for the cartilage ossicoplasties, because we use a cartilage extensively for creating the ossicles too, like a boomerang, umbrella, and so many things. We don't use those typical prosthesis of torp and porp. We create with this cartilage. Why tragal cartilage? Because it has got even in all the thickness, while the conchal has got a curved one. So you can go up to here. Okay, I think I have dissected, and now one incisor at the incisura terminalis. Then down at the bony and cartilaginous junction, then at the inferior part. Okay, can you see this?
Yes, yes.
Easily it has come, that's all. And now you can keep it over the, show me how much I have harvested. So this is the grid over the slice it. So around 15 millimeter by 15 millimeter. बहुत अच्छी है, ठीक है. Just as a surgical exercise, जब अगर आपको चाहिए only perichondrium, you can just peel it off like this. Look at this. Can you see this? See this? Hello?
Yes, yes, we can see.
Yeah, please. त्याला चांगलं सॅव्हलॉन लावणं. ते फॉगिंग व्हायला लागलं ते वाऱ्यानं ते ह्यानी. अच्छा सैवलॉन लेना, क्योंकि जो एयर कूलर है और ये उससे वो फॉगिंग बढ़ रहा है उसका. हाँ, सो दिस इज अ फॉर्मलाइज्ड वन, बट दिस इज हाउ यू कैन take it. Now see this. If you take this, this becomes an island one. So this much of big graft. Okay, this cartilage you can use it for the atticoantrostomy, whatever inside out mastectomy you have done, you can close it with this, and the same perichondrium can be used for the tympanoplasty. Okay, so this much big graft, look at this, this has become. So this is just for the demonstration. Okay, so let's move forward. Now you can just take one or two suture here, and that's all. The elevate tympanomeatal flap, put a graft, come out for the underlay. But I will show you end oral approach and how to take a post oral approach, just because this is a cadaver here, for that only. So for the end oral, there is a 3 incisions. End oral speculum hai. So number 1 incision is Lempert 1 is through the incisura terminalis from the, yeah, I will apply. This is the end oral speculum. Get oriented. This is anterior wall. From here the cartilage has been taken. This is a posterior wall. This is the incisura terminalis, inferior wall. So the Lempert 1 is this. If you have got the weight bone, you can do it, and from the same incision I can harvest the temporalis fascia. So this is a Lempert 1. Then from the 12 o'clock to 6 o'clock, at the bony and cartilaginous junction, there will be the Lempert 2. Okay, this is Lempert 2. So this is nothing but from posteriorly, if you come, so this becomes a meathectomy. And then Lempert 3. This is a periosteum, periosteal incision. So once you elevate here, so directly you will see the Mac-Evans triangle. We will try seeing that. We create a flap by giving the Lempert 4 because we have designed that. So from here, got this idea?
Yes, yes, got it.
Huh?
Got it.
Yes. So Lempert 1, 6 o'clock to 12 o'clock from in the bony and cartilaginous junction. Third is over the periosteum, and then fourth is here. So this flap is created. This will be retracted. We applied 2x2 retractor here, and now you can carry out all the work here. Okay. So we don't need a post oral for the endoscopy. So just again a 2 stitch, and cartilage we harvest from here, the same incision. So only 2 stitch will be there. Okay. So just I will show you where is the Mac-Evans triangle from here. Mastoidal space here. SMR elevator क्यों हो गया? So from here, if you will go, see this. This is the bone. Can you see the spine of Henley?
Yes, yes, we
This
can
is
approach
one.
the mastoid through this.
Yes. So this flap is created. We'll go near and see. We do everything with the inside out approach, and that should be the way. That is what we are propagating, because where the disease originates, you should follow the disease. So this is the spine of Henley, and this is McEwan's triangle. This is temporal line. This is a perpendicular or tangent to the external auditory canal. This part, okay? If you go on drilling from here, the mastoid antrum will get opened from here, okay? So that's an approach for your varia technique too. So from here you go on elevating tympanomeatal flap and you will complete your all middle ear surgery approaches. Got it?
Yes,
Let's
yes,
go near.
clear.
See this. Any question? You see this? This is a posterior tympanomeatal flap. Here is a tympanic membrane, okay? And when you come from behind, this is nothing but your meadotomy. And we create a inside out, and whatever we reconstruct, and this flap lies back over, and nice canal is formed. Okay, so let's go now. And from here only, I will just show you, give the artery forceps, how we harvest the temporalis fascia here. I got 2x2 retractor है, एक सीजर इधर. एक बड़ा वाला सीजर है. And this is how we change the approach with the endoscope holder. So this is anterior wall, this is posterior wall, and from here this will be the temporalis fascia. To the right angle आहे. आणि काय का right angle? Oh, yes, my elevator there. Yes, perfect, perfect. Yeah, yes. हाँ? नहीं अभी सब पूरा करे बगैर जब तक मिडिल ईयर में नहीं जाता है कुछ नहीं. ऐसे मार एलिवेटर. हाँ ये मग त्याच्याकडे काय आहे इन्स्ट्रुमेंट आहे का राईट अँगल आहे दे राईट अँगल आहे artery forceps. So if you will go from here, just dissect. And that's your temporalis fascia. Obviously little bit tough initially to do, but once you start doing it, you will love doing this, huh? And we don't need any post-oral and all. See, that's an temporalis fascia. Thanks to my boss, where I have learned that's an ABR Desai sir, this end oral, everything. He used to do everything with the end oral approach, and I have mastered that, and now it is helping me for the endoscopy, okay? And then from the Würzburg, for the COCon, Robert is coming, and I have mastered this. This is from the Plester's group. They do it everything with the end oral and cartilage tympanoplasty, where I have trained. That's called Würzburg University. So that's your temporalis fascia. Got this? So how endoscope help me here? See, now if I give the angle, you can harvest as much as, see this, you can see anywhere. Give the angle. Look at this. What temporalis fascia is in front of you?
The endoscope holder offers an excellent view. Its maneuverability is excellent, sir. We can hold it in any direction, and it is very comfortable and handy to use.
And always remember, we take 3 years to master the microscope. Still, after that, we go for 1 year, 2 years of senior residency. Still, we find a difficulty. So don't expect that immediately with the 7 days of training and all, you will become a master with the endoscopic ear surgery with 2 hands. But definitely, if you are a good microscopic surgeon, the learning curve is fast. You can easily carry out, and within 1 month you can try doing that and you will master those things, okay?
Learning is a continuous and slow process and requires a lot of patience. It is for our junior colleagues as well. So those who think that we can master the art of surgery and using the microscope and endoscope very soon, they have to be patient and to learn the skills.
And then saline. So this is for the, okay? This is nowhere in any mastoid dissection course, nobody shows you temporalis fascia and all, but you have kept a very nice this body, so that's why I'm demonstrating. It's good, yeah, because this has to be done.
Yes, sir.
Chalo. So, typically, what you do for the post-oral, so I am normal doing demonstration, okay? See this? Yes. And now 15 number blade. Feel free to ask me, because this is never demonstrated anywhere, this end oral approach and all. This will be something different, okay, for getting oriented, but not much tough. Just oriented again. See, what is the beauty of endoscope? If using the mic, you will be seeing, but I can see the tympanic membrane here. This is a McEwen triangle. This is a spine of Henle. This is a temporal line, and this is a muscle, temporalis muscle. So then
one basic question that is asked all the time: what should be the basic size of the graft that to be taken for tympanoplasty?
Our eardrum is 10 by 10 millimeter, so at least you have a 12 by 12 millimeter. A simple way is to have a 8 आने का आजकल मिलता है क्या? अठन्नी मिलती है क्या?
अठन्नी तो नहीं मिलती है सर, किसी के पास पुराना
अठन्नी आजकल नहीं मिलती, तो 1 रुपए का कॉइन ले लेना, and it is autoclavable because that's a very nice metal. So you can autoclave, you can keep it, mark it, and take out that much of graft. That's a perfect measurement for your graft. Even it for plasty or for the mastectomy. Okay. So again,
so during the, sir, one more question. During the placement of the graft, is it good to have a bigger graft or is it good to have a smaller graft? I mean, which is good for the post-healing process?
This will be friable here, but no problem. See, can you see the muscle? Hello?
Yes, we can see the muscle
Yes,
and the
see,
graft.
look at this, very nice muscle, and then this is a fascia. I am really happy for this nice cadaver, although it's a formalized, but it's very nice to demonstrate. Thank you once again to the whole of the team and the Farooq and team. It's very nice. I am enjoying.
Yes, sir.
Yes, sir. Thank you. Yes. Now you need a long scissor. नहीं है तो छोटा दे दो इधर, कोई प्रॉब्लम नहीं. सीजर था इधर, मैंने इस्तेमाल किया था. हाँ. आर्टरी फोर्सेप्स. This is just for the demonstration because this is a formalized body, but how to take it out, I am just showing it. it will be a very less graft, but this is how you need, and because a long scissor is not there, so it is not reaching, but I will just still manage. Hai ka moti scissor? Okay. So this is our ASM grid. It's very small, just for the, because the sake of demonstration I have taken, and this is a formalized one. So you have temporalis fascia 2. So just let's go just for before going for this, and then we will chop out the, just to show you post-oral. Give the 15 number blade. For the pediatric, you need to be little bit away, because the official, for the adult at least 5 meter. The typical plane will not be there for this. So we will join that to our myototomy. Okay?
Yes, now you have taken a postural route, and
Yes, and now you can make a rectangular or triangular flap, whatever you want. Give me the 15 number blade. I don't use this post-oral approach because for me it's a minimal invasive endoscopic ear surgery, so I carry out the transcanal or maximally end oral approach.
in post-oral approach, we can use this flap for obliteration of the mastoid cavity.
Yes.
Like you can take a inferiorly based flap, or you can take a posteriorly based flap, and you can obliterate the cavity.
Okay. And then already myototomy has been done by the end oral approach, okay? From here. See this, we have joined here. Can you see?
Yeah,
So,
clear.
Angle दे देंगे थोड़ा सा, okay. So again, and from post-oral you are harvesting the temporalis fascia from here, okay? This is a McEwan triangle. Can you see the spine of Henle?
Yes, yes, we can
This
see.
one, okay? So this is the whole of the mastoid cortex. And then you apply 2 by 2 or whatever. Just for the demonstration I am doing this, because I will be showing you the all endoscopic here. But when you will be doing cortical mastoidectomy, you will be starting from here. Okay. So your idea for drilling for the cortical mastoidectomy, this is your anterior limit, this is your superior limit, that's a temporal line, and then behind. So start drilling from the antrum and go on widening, okay? So that exercise I will see you when you will be doing there. I will be behind you to do that, because majority of the bones are the dry bones, so you will be starting with the cortical mastoidectomy only.
Here
Okay.
we have to do sequential saucerization.
Yes, then there are all things, typical classical cortical mastoidectomy you will be doing. But first, let's go. Can you, have you understood this?
Yes, yes, we
Yes.
got it.
So
we
now-
have to start from the McEwan triangle, and we have to do saucerization.
Typically, what I do for when I do the transcanal, Now it's not possible here, but still I will show you. You take one stitch stay suture from here to pull the pinna. That's called initially described by the Tarabishi. Tarabishi, the father of endoscopic single-handed ear surgery, and then we have modified it by taking two. So this is a simple cutting needle, or you can use 1/0 silk. Go through this and come out. Imagine this is an intact canal, and now and then when you are doing a transcanal approach, just see, by pulling this you get a 1 millimeter. Can you see that?
You have to take a posterior stitch.
Yes, this goes through the typical if you consider this is a left ear, this is anterior wall, this is a posterior wall, this has been taken at the bony and cartilaginous junction. So put a clock. So here will be 12 o'clock, here will be 3 o'clock, this will be a 6 o'clock, it will be a 9 o'clock. So the incision is at the 3 o'clock and you are pulling it and then fix it. That's all. This is a stay suture. Like you do for the thyroid surgery, you take a stay suture. We have modified it. We take it at the 2 junction at the 5 o'clock and the 2 o'clock, and then we pin this pull like this. So that our colleague Dr. Parab has done that, and then you get a 1 millimeter extra space. Got this? This is called a Tarabishi stitch.
Yeah.
Okay? And we are describe that. So let's go and chop out the pinna. Okay? I am going to chop out the pinna. Everything clear? Anybody wants to see anything with the pinna?
No, it's clear. We can remove the pinna now.
Just if you want to harvest the conchal cartilage, you will harvest the conchal cartilage from here. Okay? So if you are taking the post-oral, you can go from here. So no another incision. If you are doing end oral or the transcanal, you can take a small incision from here and you can harvest the conchal cartilage. Okay. Give me the motha wala de. So let's chop it out.
The delegates who are watching this, feel free to ask any questions. I am sure sir has been demonstrating very well and precisely, but your questions will enlighten us too. So any questions from the delegates, they are most welcome. So any difficulty in any step you can ask, and sir will re-demonstrate it. I hope that is not an issue.
Feel free to ask. Feel free to ask, because each question is an important question. There is nothing called silly question. Otherwise it will become a monologue. I will be just telling you. If you will ask very small questions, I will be elaborating more and more around that. So you will know more. Okay? So clean, चांगलं ह्याचं ड्राय होणार आहे ते त्यामुळे जर चांगलं भरपूर घे. Forceps. हे कुठले आहेत? उद्या हेच देणार आहेस का काय? Normal saline. Now picture is good. Forceps.
Yes, it's clear.
Get oriented, because the anatomy endoscopic is different. Anatomy is same, but orientation is different, because what you are seeing here is through the endoscope. You are looking at the monitor, the way you are doing it for the nose. So we'll create a flap. Let's go first for wash. So typically we will take a, once again, anatomy little bit, and then we will take the transcanal incision. Give me the ball point just to show. Anterior wall, posterior wall, superior wall, inferior wall. So you can see a small light reflex here. So here will be the malleus. This is a this lateral process of malleus, and then sharpness membrane. Can you see that?
Yes, yes. So
Lateral
we are
process
going to
now.
do a tympanoplasty first, or we are going to the stepidotomy?
Let's take this out. Wow, this is good. Now it's good. So this dirt, once you remove, see this. Let's go near. Now it's a beautiful picture. Lateral process of malleus, handle of malleus, antero-superior area, antero-inferior, posterior-inferior, posterior-superior area. So, if you, why endoscope and why inside out? Because this is the way, all the cholesteatomas originate from here, travel to the epitympanum, that is an adipocyte antrum, and occupy the mastoid antrum. So where it originates, if you start following the cholesteatoma like this, your cavity will be small. You can reconstruct it beautiful way. Let it be extensive cholesteatoma. You can take it out inside out. You keep the facial ridge high. This is totally against the what contemporary things we have learned. What we have learned, lower the facial ridge to that extent that it will be at the external auditory canal floor. Here I will be keeping much more higher, so that you can nicely create the mastoid behind it. Okay, that's an idea. So that's a new concept for what we are doing. So we are giving the cavity-free area. So it's clear this, and even just imagine for the endoscopic septoplasty, my two hands are free. Take a transcanal incision. Go ahead. So let's take a transcanal incision now. So we will reduce the zooming so that panorama will be much more better. Yes. Suction बघू मी त्याच्यात बघितलं चालेल फ्लश करून circular. So now why two hands and why this suction in your left hand? Typically in a single-handed endoscopic surgery, you are taking the endoscope in and out again and again for the fogging. But here this suction will take care of my fogging. Also it will cool the area. Okay, it will cool the area. So just as a transcanal incision, I typically take a 360 degree or 270 degree incision. I will classically show you. Angle wala. So now these things doesn't reach here, so I need an angled circular. That is what our idea.
So do we need any kind of special instruments for this endoscopic surgery, or we can manage with the micro instruments?
Yes, that's why we have changed little bit. See, I will use here, it is not reaching. So I have given the extra angle to circular. Look at this. नहीं दिलेला है, ये नहीं है. Angle वाली दे. Even this is a, but you can manage it, but with little bit of difficulty. Give me the angled one. But just see this angle now. I have given this angle
Yes,
extra.
yes.
See the beauty of doing the ear surgery calmly and quietly with the endoscope holder in place. But believe me, you need to have a little bit of training for this, but your patient will be happy. Yeah? And again I reiterate, I work in private hospital. I take thousands and lakhs for the surgeries. So if I can do it, believe me, you can do it. The rest techniques are similar. Microscopic techniques. Some problem with the audio. मूव हो रहा है या बैटरी खत्म हो गया. हेलो. हाँ.
Hello, auditorium.
Yeah, we can hear you, sir.
Yeah.
Battery is okay.
Please ask the questions. All questions are welcome.
Anybody wants to ask anything? Any
Again,
questions?
I will add one thing, because if tomorrow there is a live surgery, the same repetition will be there. But instead of cotton ball or cotton plates, I use a Merosil small pieces soaked with the xylocaine with adrenaline. Why so? Because when you are using the cotton plate, you are leaving the lint behind, and that could be the reason for the some failure. So I am trying to go and reach the bony annulus. Get oriented again. I have rotated the endoscope. Anterior wall, posterior wall, superior wall. My suction is in the inferior wall. Typically you do transcanally with the microscope too. Okay? So I am doing it with the endoscope. Why endoscope? Look at this. Everything is in front of me. When you are doing it with the microscope, the only some part of will be in front of you. And whenever I want, you can go very near to it. That's all. So let's go. छोटा वाला आएगा.
The flap is very thin inferiorly. It is very difficult
Yes.
to elevate that. Just see the steps. The sir is not pushing suction anywhere near the flap because it is already too fragile and thin.
Yes, that's a good point, Farooq. Because you traumatize the flap there. You have to take care. Huh? So now I have reached the posterior notch of Rivinus.
Now we are reaching the annulus level, sir.
Yes. This is an epitymphanum. So let's go.
Elevation is from 1 o'clock to 6 or 7 o'clock, I guess.
Can you see the annulus?
Yes, we can see.
Can you see? Yes. So let's go. Now I want a cecal.
Now you will be incising the middle ear mucosa.
Got it? And I am through. Nowhere extra pressures, nothing. Lateral process of malleus. Can you see that?
Yes, we
This
can
is
see
the-
the lateral process, and we
Serious.
are going anterior to that.
Now I will go here.
Tip of incus is also visible.
Now I will use a flag knife. Can you see the incudostapedial joint?
Yes, we can see the IS joint.
Yes. Look at this far angle. I have given the angle to this flag knife. So when you develop the tools around that, then this surgery becomes easy. Never get disheartened that अरे यार ये सिर्फ खान को जमता है और कुछ नहीं. तुम करो, then पता चलेगा कि मजा क्या है. And that's all. You have to elevate, freshen the margin, put a graft, and ask the patient to give for the stitchless surgery 80,000 rupees.
Yes.
हमारे इधर तो मिलता है.
इधर नहीं देगा सर. उधर बोलेगा निशान दे दो, 20,000 रुपया है मेरे पास.
So the thing is that it's because there is become that's on lighter note, but the life is easy. With anesthesia also you can carry out this procedure beautifully. Okay. So go here. Now I will show you how to denude the malleus, because I keep the graft over the malleus because my graft of choice is slice cartilage. If there is a perforation, you can just do the underlay technique, put the graft, come out. Classical way, I bring interlay. So, so along with the annulus, along with the annulus and squamous epithelium layer, and put a graft between the mucosa and fibrous layer. Multiple problems, so need not to do go. So this is classical way. I have elevated the. So along with the mucosa, why interlay? There is some problem of 2% where you get a mucosalization of your graft. So for that you need.
So here you are going to place the graft medial to the malleus, long pros.
I will show you how to denude that malleus. I think this is better. A छोटा section ले. Can you see the whole of the malleus?
Yes, yes.
Yes. Now I will take a periosteal incision over the malleus, and this is you need to do it to avoid mucosalization now, because you keep the graft under the malleus. So you have to denude it and then get extra 1.
So that epithelium is not left behind medially.
I hope this picture is good for you, because I can see a good picture. Lateral process of malleus, through sac space, posterior notch of ravenous, down this. If I take this small bone that I will be showing you, the chorda will be there. I can see the ecoscapular joint here. So, and yeah, you said.
It is to be done very gently, otherwise there is a process of dislodging
हाथ में आ जाएगा.
the ossicular joints. Watch very carefully how gentle sir is with the strokes and how slowly is giving the periosteal incision.
Although this is a formalized bone, it will traumatize, but just for the sake of demonstration, I am doing that. Can you see this?
Excellent, sir.
There they go. Now and out. ये लो खत्म.
Wonderfully removed, sir.
कहाँ है कुछ मैं कर सकता हूँ तो तुम कर सकते हो.
Sir.
That's all. But the beauty is the endoscope. Everything is in front of you. What you are going to damage? सब कुछ सामने है. बम्बई जाना तय है, रास्ता मालूम है, कहाँ है, क्या है, किधर खड्डा है, गाड़ी वैसे ही चलाओगे. That is the simple way to do the endoscopic ear surgery. Okay?
सर आपको एक्सपीरियंस ड्राइवर है, आपको सब गड्ढे मालूम है, हम लोग गड्ढे में फंसते हैं.
एक्सपीरियंस ड्राइवरिंग के लिए मेरे को भी 10 साल लगा.
That is the point that I want to validate.
Yeah.
Surgery is a learning process, and learning is a very slow curve. So you have to be very patient.
Yes, but if you want to do it, because the whole life we are going to be an ENT surgeon, so take time for the learning. No problem, you can do it. Now we have developed that sheep head technique also. बकरा तो 400 रुपये में मिलता है, जे ले जाओ वो अपने को फ्रेश है, डू इट, द सिमिलर ईयर इज देयर एंड यू कैन स्किल. So that's all. And yes, so now this is how I elevate. Beautiful anatomy. Eustachian tube. See the beauty of endoscope. I am not with it. The Eustachian tube, canal for tensor. This is a supratubal races, and here will be the tensor fold. बाद में मैं दिखाऊंगा जब वो निकालूंगा इसको तो. And if you put a graft and repose back the tympanomeatal flap, thing is that. तो perichondrium मेरे पास है, रख देंगे दिखाने के लिए. Then we will. कहाँ है perichondrium वो?
The anteriorly also you have removed the annulus, sir. Anteriorly.
Yes.
Anteriorly also you have removed the flap, and we are going to place the graft anteriorly also.
Yes. वो हम तुमको ये दिखाएंगे because this is a circular. You can go, I have already gone from here, see, around almost underneath, see from where I have come here up to, only it has stuck at one point. Can you see that?
Yes, sir.
Okay?
Yes, sir. Very well visible.
So ऊपर से भी और नीचे से almost 360. नजदीक जाके देखेंगे. Look at this.
Yes, sir. In the interlay tympanoplasty, we leave the mucosa
Yes.
behind. So it takes a lot of experience to peel off the mucosa gently from the epithelial layer.
So just for the sake of demonstration, so type 1 tympanoplasty, whoever having the good bone, they can just practice it. Forceps. This is a bread and butter surgery and one has to do it perfectly. Once it fails, you have to take care of your patient. So, ठीक है इसका. It has become a dried one, no problem. थोड़ा सा पानी है ना. Normal saline दिख रहा है? It's very dry. Cecal.
Sir, you are using a dry graft always or a wet graft?
It hardly makes a difference, huh? But dry graft is very nice to manipulate inside, and later on you can, but doesn't make a difference in result. But I prefer a dry graft. Huh?
Dr. Satish Jain is a propagator of wet graft.
Yeah.
So both techniques are good. It depends on how well versed you are in doing
because
which
there's
technique.
nothing but a fibrous tissue. Temporal is fish, and also viability question is hardly a. So this is just for the demonstration, and then repose back ball point. Later on I am going to take out all the flap. This is a fragile one, that's why this has happened, but don't worry about it. This is for the demonstration. I have just done this. While doing this, I use a ab gel so that
it is difficult to demonstrate here because the skin has become very thin and atrophic.
yes,
And the handling has become very difficult. In the live surgery, it is not so difficult.
yes, because this is friable. and now ask the cadaver to give at least 40,000 rupees.
He'll give you there, sir.
Okay, serious. Okay, so this is a type 1 tympanoplasty just for demonstration. So we will take out now the...
Wonderfully demonstrated, sir.
Yes.
Very good. Yeah.
We need applause from the audience. So,
Round of applause from the audience here.
So now we will take this out. Give me the flat knife. We'll take this out, everything, circular knife or flat knife.
so what are you planning next, sir?
I will show you posteriorly taking out some bone and then do some endoscopy, middle ear endoscopy. And I think we will stop and then we will ask them to kitna baja abhi? Otherwise I can.
12 बजने में 10
हाँ?
मिनट।
अच्छा इनको कब देना है डिसेक्शन? Because they should start. They should. हाँ.
We are going to do a stepidotomy.
Yes.
Are you going to do a stepidotomy, or you were like you will be showing the ossicles?
इसमें अगर हो सका तो कर देंगे. But this will be. Let's see first the condition. Okay, give me the curate. Look at that curate also. I have bent that.
Now the chorda is coming into the picture, and we have to be careful while curating this area.
Yes.
Our instrument should move away from the vital structures.
Right. Just be careful if you want to take care of the chorda. Can you see the chorda down?
Yes, yes, clear.
थोड़ा सा मोटा सेक्शन है.
Suppose while curating, you have injured the chorda, and then it's better to cut it sharp.
Yes, better to cut it instead of avulging it. Cut it so that dysgeusia will be avoided. So
Yes.
yeah, sharp cut.
Sir, which curate you are using? It's cutting very smoothly.
Come again.
The curate is of which company?
This is our own Santosh Surgical only.
Okay.
But I have bent it with my tool. Okay. Can you see that external camera picture?
Yes, it's cutting like Storz curates, so it's better than Kalelkar, I guess.
Yes, but why it is working? You know, because after every 15 surgeries, I sharpen this. So there is my technique to sharpen this. Otherwise, what we keep on doing, we use the curate permanently for the all surgeries. After 10 surgeries it goes. Let it, if there's Storz, it will go after 50 surgeries.
How to sharpen it?
So sharpen it with the under microscope. I use a microscope only for sharpening the instrument, not for the ear surgery.
Yeah.
So I use a 1 millimeter diamond burr, and then under microscope I sharpen this.
Okay. It looks very sharp.
Yes, जैसा अपना वो धार लगाने वाला आता है ना, कौन सा वो चाकू को धार लगाने वाला, तो उसके जैसा अपने को भी करना है. So all instrument you need to sharpen it after every 10-15 surgeries.
Yes, but you great point. So we should make our instruments sharp before doing for.
Yes,
going for
that
the
video is there on my YouTube channel. You can just go through that. Dr. Mubarak Khan करके YouTube channel है. So I have uploaded that video how to sharpen that. You have to be very, very careful when you are sharpening. Otherwise, you will damage the instruments. You have to see this very thin instruments. Huh?
Now we'll be seeing
Yeah.
long process of the incus, just medial to that.
Now you are able to see the long process. Okay.
Yes, it's coming into the picture.
Curate. Be very gentle. One small stroke and the ossicles will go. So I am coming out. I am not going like this. One important thing is that when you are using all these instruments, never use your shoulders. Our typical body's technique is that you start using the shoulder. Shoulder has to be used by the orthopedician, not by the ophthalmologist and ENT surgeons. ENT surgeon and ophthalmologist has to use only the hand, fingers and wrist joint, nothing more than that. So you have to rest the things and only like the way you do the signature on your check, the instrument has to be used like that.
And you should come from deeper to surface, from medial to lateral.
Yes. So if you have got a nice sharp curate, you can do much more work. You can even do the aticotomy too. Just need to be patient. Better.
So does the endoscope produces heat like the light source inside the ear? After some time, using it for some time.
Oh. About the heat issue?
Yes, yes.
So that is what we are propagating. When you are using the suction in your left hand, it is taking care of the heat generated inside. It is continuously taking off the heat around. So there is no problem.
Okay. And we can also irrigate intermittently.
Absolutely. So you can keep irrigating. You cool the endoscope. That's another advantage what we discussed in our laryngoscope paper. Can you see the beautiful facial in front of you?
Yes, yes, we can see the facial.
Yes, and that is what is all panorama of the endoscope. Between that facial and all one space, that's a posterior isthmus. Behind the long process of the incus. So I will curate little bit more just for the demonstration.
And you can also do facial nerve decompression by this approach.
Absolutely. That's called a transcanal decompression. So from there downward, you can just go on.
So if there is
taking out the bone over the facial.
If there is a fracture line running through the posterior canal wall, you can follow the line. If it is near the horizontal canal, then you can decompress that area.
Yes, that's right. Even if you want to drill, we have developed that auto shield that's called a protector, drill bit protector. Rafiq, anle gade. So drill bit protector that I will be using for the inside out. So it covers your rotating burr and avoid the trauma to the skin and your endoscope, which is valuable.
Okay, that is very good. Like normally while drilling in the nose or in the ear, we may damage our costly
auto
endoscope.
shield. Look at this.
External camera, please show the holder.
External camera, can you see that? No.
Show sir's hand.
Oh, no, sir. Is there?
Little bit lower, sir. We can
Yeah.
see. Yeah. Now we can see.
Yes. So you can see that. So this fits over your handpiece. Typical simple marathon handpiece. It's there here.
And there are two knobs. One is
Yeah, just see this. That's all. This is your handpiece. Now, burr. That's all. Now it will keep, this will go, इसको बैठेगा क्या ये? नहीं, ये इसको नहीं बैठेगा handpiece. And this will, when the drill bit is rotating, this will protect. Okay?
we can use it for drilling inside the ear, then we can see that, sir.
Yes, one is for the suction, and another, this is for suction, this is for the irrigation.
Okay, that
So
will be
everything.
self-irrigating.
So you will go on doing the things. Simple innovation, but will do much more thing. Same thing, there is, we call Auto Shield N, that's a 90 centimeter, 19 mm, sorry. Can you see this?
Yes, we can see that. The
This
other one is for what?
Long one, that is for the nose, that is for the nose, it will reach anywhere.
Okay.
Okay?
Got it.
So this is a simple innovations and you can carry out the work. When you are drilling, it will not, even if it touches to the endoscope, it will not damage your endoscope. It will not damage the skin around the nose or the skin around the external auditory canal. Okay? Yes.
These are universal adapters, or it will only attach to the marathon?
I am a poor surgeon, so my छोटे छोटे चीज़ों के लिए बनाया. This idea came when Satish was doing, when Bangladesh we were doing, he was doing the anterior skull base,
Yes,
and the Zomed has got that anterior skull base burr. That's a disposable burr, and that costs us 32,000 rupees. And that's completely covered and it goes to the sphenoid. So मेरे दिमाग में आया भाई ये इतना तो 32,000 लेके पहले मैंने किया एंडोस्कोपी में. पेशेंट पूरा सर्जरी का कॉस्ट 32,000 दे रहा है. Where I will use that in the year? So then I thought that why not to create it. And then I use the marathon drill. So मैंने पहले marathon को किया है. But this will be adapted for the other. Okay? Now we are adopting it for the other. But at present this handpiece can be fixed to any your Zomed, not Zomed, but your Bioneer and all, it can fit. And this has to be used from the marathon. Okay? So this is a simple. Yeah.
This has made the life very simple. This is a simple innovation made by a great mind. Right, sir?
No,
Simple innovation by a great mind like you.
No,
So
simple
many
innovation by the simple surgeon and the poor surgeon.
For our scenario, it is very useful, sir.
No, my idea is always to have कि जिस कंडीशन में मैं काम कर रहा हूँ वैसे ही कंडीशन में लोग भी कर रहे हैं कहीं ना कहीं. सो आई नीड टू क्रिएट दो स्मॉल थिंग्स फॉर दोज. अगर मेरे लिए मैं लाइफ इजी कर रहा हूँ, दैट विल बी इजी फॉर द ऑल. ओके,
So nice of you, sir.
या
Sir, is it commercially available or is it
yes,
exclusively for you?
it is available with our company only. Dr. Khan's creation. तो अपने
Sir, we
and
can order it
hard
online.
cost you some 4,000 or something like, and it will for universal for the life. जब तक कोई लेके तोड़ेगा नहीं टूटेगा नहीं. ओके, जाओ ऑटोक्लेव करो, अच्छे से उसको क्लीन करो, इट विल वर्क परमानेंटली. गिव मी द क्यूरेट ना. I think this much is sufficient just to show you the approach for the steppies, and we will do the endoscopic middle ear anatomy, we'll see, and then we'll stop here and ask the people to join for the dissection. तू हे आणले का स्टेपीस बर आणलाय?
So here the
Static
exposure is very essential. The optimum exposure should be achieved before going for any further procedures.
Come again, I didn't understood.
So the exposure is the key. We have to expose it properly before going into the depth.
नहीं just Sika. First we will do the
Sir, normally by using macroscope, we expose up to the pyramid. So by doing endoscope, is it
yes,
required
that is
less
the
exposure
advantage
or
of
we
the
have to
endoscope.
expose
You
up to the
need not to
pyramid?
take out lot of bone there. Okay. So इसको थोड़ा सा zooming in करेंगे. So that we will,
Classical teaching is we have to expose the just beginning of the body of the incus, the facial nerve, and the whole stapes foot plate. But in endoscope, I think we can limit our exposure.
you are right. Yes, ball point. Now see the beauty of the endoscope. Everything is in front of you. I can see the anterior isthmus, I can see the posterior isthmus, I can see the facial, I can see the stapedius chorda. So let's go. This is the anterior wall, posterior wall, superior wall, inferior wall, handle of malleus, lateral process of malleus, Prusac space, chorda tympani.
Processus cochleoformis is also.
Absolutely, I am going to show that process cochleoformis beautifully by this area between the malleus and incus is nothing but the anterior isthmus. 80% of the ventilation of the mastoid is through this. Can you appreciate this?
Yes, that is the anterior isthmus.
So this one, anterior isthmus. Behind this is nothing but a posterior isthmus. This one, this black space. So this is 20% ventilation. This is 80% ventilation. Here, this is nothing but a epitympanic diaphragm. The ball point which is going here will be the tensor fold. So the tensor fold in 25% cases they have got an accessory opening. So through that also its anterior epitympanum is ventilated. But in my typical all surgeries I open this. So for that also I have made that instrument. So open this. So additional ventilation will come from here. The all problems are due to the ventilation. So this is a tensor fold here, you have to open it, okay? For
Yes.
let it be a simple tympanoplasty. Then it becomes a functional endoscopic middle ear surgery and not just a tympanoplasty, okay? एक छोटा section दो. So let's go for the other to identify the other landmark.
Can you defog the endoscope a bit? Like some greenish dots are coming.
Come again.
Defogging, anti-fogging the endoscope again.
Right now?
Yes, some greenish dots are coming in.
Yeah, now here I can see a beautiful picture. I think that's a problem of it. We have a fantastic picture here.
Okay, no problem. We can manage with it, sir. We can go ahead.
Just can you, audio visual, can you see that? So,
Green dots दिख रहा है. Green आ रहा है थोड़ा. इसको थोड़ा ठीक.
let's go down. We'll take this out. So just little bit of angle. This is a 4 millimeter endoscope, okay? If
Yes,
you are
sir.
using the 3 millimeter, chota section there. Then again you have got an ample amount of space. And I typically use a 3 millimeter endoscope.
3 millimeter 0 degree or any angle?
0 degree. 0 degree is always a better. So keep an eye now. That's beautifully you can see. Can you see that processes cochleariformis and tensor?
Yes, we can see.
This is a tensor tendon, anterior isthmus. You can see the stapedius. Can you see this?
Yes, glossopharyngeal nerve.
Jacobson's nerve, right?
Yes, we can
Yeah.
see Jacobs.
So the typical anatomy, where it starts, that's nothing but an funiculus. So from here, it goes Jacobson's nerve. Where it ends, it's a processus cochleariformis. So that's a rough landmark. So anteriorly there will be, this is the
It
one.
arises from the hypotympanic area, then it continues
Yes.
just anterior to the processus cochleariformis, then continues as a lesser petrosal.
See where it is ending. See this. Look at this. So that's a rough landmark. If you know one landmark, you will find out the other.
And this
Now-
nerve also lies just anterior to the round window.
Yes.
Sometimes in difficult situation, it helps in identification.
Can you see this stapedius and the pyramid? Stapedius
Yes, sir.
tendon
Yeah.
and pyramid?
Yes, we can see that.
Yes. I hope idea is clear. I am going down little bit and the facial just behind. So again, for the sake of discussion, I have made one small formula. From 3 millimeter posterior superior to both the crus, 3 millimeter posterior superior to the both crus of the stapes facial, okay, tympanic part. 3 millimeter posterior superior to that lateral semicircular canal. So if you come from behind, if you find out the lateral semicircular canal, make sure that it will be 3 millimeter anterior inferior to the lateral semicircular canal. There will be facial. 3 millimeter anterior inferior to the tympanic part of the facial will be the stapes.
Yes.
Got it?
Yes, yes.
So in cholesterol, many landmarks are lost. This is how you can just remember, okay, for the practical purposes. So come here. See this is from the distance, and then coming from here, very near. Let's focus here. Yeah, that's better.
Now we can see the pyramidalis process and the stapedius tendon.
I hope the idea is clear. In front of them there is an eustachian tube. Just below that there is a bony plate which will be separating the carotid. Okay? Come down, there is an hypotympanum which will be separating this bone, separating from the jugular. Promontory, the landmark is a Jacobson's nerve, where it starts, funiculus, where it goes, processus cochleariformis. Processus cochleariformis, not many changes happens. Tensor tympanic takes a curve and gets insertion over the malleus neck, and from there only the first genu of the facial nerve is there. From there only the branch, that is facial and superior petrosal nerve starts there, okay, and from just you go upward in the epitympanum, in a tegmen tympani, the bony part which is separating the anterior epitympanum from posterior epitympanum, that is called the cog. I will show you the cog once I will take out the all ossicles. Okay?
Sir, you can show the ponticulus here. I think it's visible.
Ponticulus? Okay.
Yes.
So here I have to take this little bit of bone, and this is a 4 millimeter endoscope. I hope, yes, it is there.
Yes, yes.
Some bony part is there. Can anybody show there? Some bony chip is there falling. Let me take this out. Let's take this bony chip first. Suction थोड़ा सा, आणि मला सिकल है. This is the bony chip. छोटा सा मला एंगल वाला देतो, वेड़ा वाकड़ा वाला.
टच करके.
So that bony chip is in the sinus tympani.
Yes.
Right?
We can remove that, sir, and
Yeah,
point it
that is what I am doing, because
we have lost the picture.
you have lost. They are doing something.
Just a second, we will.
Yes, we are back.
Yes, it's there.
Yes, yes, we can see.
Okay. Can you see that?
Yes, we can see it clearly now.
Yes. Still, I can show you after taking out that bone later on. Okay. So now we are very near to that. We will preserve that, and then I will show you what is a subiculum, what is a ponticulus. This bone needs to be removed little bit. Okay.
Yes, sir.
Yeah. So, and just for the sake of demonstration, I have kept that chorda. Otherwise, we can take this bone and then go ahead. Any question on this? Or anything you would like to see? Some cure. I may take out the chorda, let it go.
Now this chorda is a very important structure. It carries taste fibers and it originates just above the stylomastoid foramen and continues in the middle ear and joins the facial nerve.
Yes, I have just taken that out because I want to show you. Suction. This is all the overhang. See, this much is down, there is a retrotympanum, okay? So, सिर्फ निकाल देंगे so that we will see the nice anatomy. Okay, and now some big suction, and we will see now the sinus tympani and sickle. Clean. बिल्कुल बिल्कुल उसके सब आई थिंक दे शुड डू मच, बाकी का तो मैं दिखाते रहूँगा, जस्ट एक बार आई विल शो यस. Now you can come to know how you can do that facial decompression transcanally, right? See this whole tympanic part, the mastoid part just behind the pyramid, relation of the pyramid with the mastoid part, okay? And then how, if you just take out this bone, I will try to show that transcanally only, and you can see, take out the nice decompression or do the decompression of the facial nerve, okay?
One point that I would like to impress upon, sir, the view of this endoscope is far superior in this area than the microscope.
Yes, that is why, and its learning becomes easy, and the newcomers will not damage much thing. When everything is in front of you, what to damage? Yes, just थोड़ा सा anatomy orientation थोड़ा अलग चाहिए, बस that's all. Give me the ball point. I will just put it into the sinus, and then we will stop here. So, one bony part going from the pyramid to, this is nothing but the
Sinus tympani area.
and this is, see how deep it is. So this is a type C. Type C means going beyond the facial. Type B is just medial to the facial, and type A is just only superficial to the facial. So see this is 5 millimeter, almost 2.5 millimeter is going inside, and compare it with the facial nerve. So this is a type C. So here you can take it beautifully with the endoscope. This sinus tympani disease, some collection is there, and I will just take that out, and we will.
This is the space medial to the facial nerve. So sometimes with microscope we find difficult to remove cholesteatoma from this area.
Yes.
Could you show us the subiculum, ponticulus?
That is what this, some collection was there. And now that sinus is quite nice one.
Sir, to visualize this area, we use 0 degree endoscope or
Zero
using
only, just
angled
with endo holder I can give all 15 degree, 20
Sir,
degree angulation.
as experience suggest you can use
No,
it,
no,
but then what we
no, with this you can do this, or you can just bend your hand and to look. Otherwise, if you are not feeling comfortable, use a 30 degree.
30
30 degree is the best one. So this is a sinus tympani. Now again, for the sake of discussion, even the pyramid has got the 3 types. One is complete, another is bridged, and second one is without just open. So let's see the kaun sa hai type. So this is nothing but your, so this is an incomplete, okay? See this, the bone going from the pyramid to the promontory is a ponticulus, then come downward, this is nothing but the subiculum, from here to here, and area in between is nothing but the sinus tympani. From the subiculum downward to the funiculus, this is subtympanic recess, this one, okay? This whole, but lot of bony overhangs may be there. Sometimes it is very thin, sometimes there is a jugular which will be dehiscent, it might be coming up, so okay, so you have to be very carefully, you have to see this, okay? Yeah, so this is about the sinus tympani. Let's go little bit near and look. So this much only with the 0 degree I can do, and this is a 4 millimeter. Otherwise 3 millimeter I can show you much more with the lab.
And we can also see the superstructure of stapes,
Yes.
the crust anterior and posterior.
So some mucosa is there, otherwise we can see the two crusts also very beautifully.
This
Is the
view
idea
good.
clear? This is the facial, and if you go on taking this bone, see this. If you go on taking this bone from here and the facial, you can just, can you see the vessel over it? Let's do it.
This is the facial recess area.
Yes, this is the facial recess, right. This much is sufficient at present?
Yes, yes.
Okay,
Clear.
so let the people start doing the drilling. So यहाँ पे सिर्फ दिखा देंगे एक बार how to this, because I hope they will be having the dry temporal bone. एक drill ले लो. Drill. Just I will mark and then I will be behind you to see how they are doing the cortical mastoidectomy. And चला. Now here, following the cholecystoma means doing the inside out is a fantastic way. Okay, so I will show you that. चलेगा कैसे, इसको जरूरी भी नहीं, इसको बड़ा लगाओ, और ये किसमें है, इसमें फुट है, किधर है पैर? हाँ, 2 मिनट, एक थोड़ा सा दिखा देंगे, हाँ, थोड़ा सा, अरे थोड़ा सा, ये कितना दिखा देंगे इसको?
Please focus it, sir.
यस, इसको जूम भी करेंगे बिकॉज वी विल कीप अवे एंड देन इज इट बेटर?
Yes, yes, clear and focused.
यस, ये बड़ा दे रहे सेक्शन, अरे 2 मिनट कर लेंगे. या again, this is a canal, anterior wall, posterior canal wall, superior wall, inferior wall. This is the spine of Henle, Mac Evans triangle. If you will start drilling from here, go up to 2 centimeter and you will face the mastoid antrum. So our typical way is to do this, take out the whole of the cortex. That's a classical cortical mastoidectomy. So start doing this. I don't do in my whole practice. I don't do this. Just for your demonstration I am doing, because my way of approach is every time it's an inside out. Okay, let it be whatever with the complications or war. I just endoscope. Even during the mastoidectomy with the endoral approach, whenever the endoscope gets blood, just wash it. That's all. Need not to take out endoscope, and that's why the two-handed makes a sense. I am just doing little bit to show you. I am not going to take out this whole bone because I want to show you the inside-out approach. But the delegates can do this all exercise, and I will teach them how to do this personally standing behind them. Okay, got the idea?
Yes, yes.
Okay, this is just for demonstration. I will see how the delegates will be doing, and I will. So let's stop here.
Okay.
Audience, should we stop?
We can reach the mastoid antrum. After that, we can start.
Acha, you want to see the mastoid antrum?
Yes, that is the
Okay,
basic.
okay, no problem. Yeah, chalo.
So the superior line is the extension of the root of zygoma.
Yeah.
The second line should be drawn along the EAC, and third line joining both the two lines.
Yes, you can just discuss the boundaries and all. Yeah, no.
That is a McEwen's triangle, and after that you can do the drilling.
Microscopically, the picture will be different. You have to adjust. You have to have and adjust your eyepiece, and then go ahead. I will be behind you to see. Now, what we are doing to use this as an exoscope, if you use a 10 millimeter laparoscope here, you will get a huge picture and everything will be in front of you. Otherwise, the exoscope costs you more than some 70 lakh rupees. But if you use just a 10 millimeter laparoscope, 30 degree. Yeah.
Now we are reaching the master tantrum eye.
Yeah. इसको एंडोस्कोप को थोड़ा क्लीन करा, उसको लगाओ सैवलॉन थोड़ा. या थोड़ा सा इसको पिक्सेलेशन ज़्यादा हो गया. बेटर. Posterior canal wall, zygoma here, down will be this is the inferior. Keep this, see this. This is the floor here. So just in the McEwan's side, so this is spine of Henle. So behind this will be the McEwan's triangle. Endoscope. Here also you can just judge where you are exactly. Look at this, okay? Like this, yeah. So initially, if you want to enjoy the endoscopic ear surgery, intermittently try using the endoscope when you are doing the microscopic surgery, and then you can turn directly, shift to the endoscopic too. There is no harm in putting the endoscope when you are using the microscope. So we have a just patch also. So we have reached the antrum.
Yes,
okay?
now we can reach.
So which can be attached to the microscope existing, and you can convert it into the endoscope holder. Suction. Okay, let's go inside and see. Got it?
Yes, yes.
I have just opened, not done much thing. If we want, we will come from the... see this?
Yeah, this is the...
That's a dome, lateral semicircular canal.
Lateral semicircular canal, yes.
Go near. Wow, that is called the endoscopic view.
And you can see the incus as well.
See this? Let me point it out with the... I have not drilled much. Give me the ball point. So I will put from here, whether it's possible. No, it's not possible.
Sir, you can come from the mastered side. I think.
Yeah,
it would
it's
be-
not possible. Let's go from here only. If I can take out, you can see many things. That is nothing but the anterior isthmus which I am trying to see that. If I take out the little bit more bone, I am just trying to see whether I can pop out into the adductus and antrum. If I take out little bit of more bone, I will see everything. Let's take little bit more bone because it's a quite good picture. ये काय है? Wash and see.
By this approach, we can address the ossicular issues, or we can remove TS patch from the epitympana. This is also called as epitympanotomy.
मला I am putting from behind. See this? Okay?
Yes, we can see the patterns.
Yeah, see this? This is coming from the anterior isthmus. Let's put a ball point from behind because that will be a little bit ossical. But we have opened the complete.
Now we can see the instrument from the
That is through the anterior isthmus.
anterior isthmus. Yes.
Should we stop now?
Yes, yes, clear.
Yes. So and we will be doing all the surgical exercises till the evening. पूरा facial visual खोल देंगे, कोई tension नहीं है. Okay. Let's people start doing the cortical mastectomy.
Yes.
So this
Thank
is
you
how
so
it is.
much, sir, for this nice demonstration. A round of applause from the audience. Thank you so much.
Thank you so much for the patience watching. Yeah. Sure. ये बंद करो. अच्छा था. बंद करो. इसके लिए तो सब दिखा. ये बंद करो. इनके वजह से बहुत सीखा है. या.
Dr. Beneath, please coordinate and please bring all the delegates to the dissection hall.
सैयद मिराज इमाम से का लिखा है। हाँ ये है सैयद मिराज।
Our next session, which is will be starting right now. It will be done by Dr. Suryakant Pradhan. Dr. Suryakant Pradhan is the one of the best ENT head and neck specialists in the city of Bhubaneswar. He has more than 10-year experience and practice at Apollo Hospital and the ENT Care Bhubaneswar. Dr. Pradhan has a special interest in skull-based surgery, cochlear implant and laser surgeries. He finished his MBBS from VSS Medical College, Burla in 2006 and MS ENT from the Institute of Medical Sciences, Banaras Hindu University in 2012. Dr. Pradhan has added various feathers to his cap, winning multiple accolades for his paper presentation in national and international workshops. He has also authored several research papers and studies specialized in issues of ENT. He is a well-known member of Indian Medical Association and also served as an executive member of AOI Bhubaneswar. Dr. Pradhan is well known for his expertise and efficient handling of the procedures and surgeries. He has successfully carried out more than 10,000 ENT head and neck surgeries in the Apollo Hospital and the ENT Care Bhubaneswar. Dr. Pradhan will be now showing posterior tympanotomy approach and the procedure for the round window insertion for the cochlear implantation. So please pay attention over here. Dissector, please, you can stop for the few minutes and please pay attention over here so that you can learn the posterior tympanotomy approach and the round window electrode insertion for the cochlear implantation. Thank you.
जो अभी बच्चे कर रहे हैं ना उसमें भी हो जाएगा. सबको यहीं पे बुला लेंगे या ऑडिटोरियम? जो डिसेक्शन कर रहे हैं उनको आधे घंटे कर रहे हैं उनको यहाँ थोड़ा बोलोगे आधे घंटे रुक जाएंगे तो मुझे सक्शन दे दीजिए. आप थोड़ा इरिगेट कर दीजिए.
Dissector, please pay attention over here. We are going to start posterior tympanotomy approach and round window electrode insertion. Other delegates, please be seated in the seminar hall. This will be projected over in the seminar hall also.
Hello, good afternoon. I'm really thankful to the organizing team and Dr. Dharmendra Farooq sir for inviting me to this event. Today we'll be having a session on cochlear implantation. All of you, please come here. You can see in this monitor.
The dissector who is standing in the back side can come front and see the screen and you can participate in this session.
You can stop your dissection for say 30 minutes. After that, you can continue that. Okay. So if you have any doubts, you can ask me during the procedure.
Somebody will be moderating. Yes. Tell some Farooq sir or somebody to moderate, please.
So in the morning we have seen Mubarak sir has done a beautiful endoscopic demonstration of middle ear anatomy and he has done a cortical mastectomy. Now I'll be doing the procedure in the same cadaver. Now this implantation starts with a post-auricular incision. First we have to give a post-auricular incision like this and then we have to elevate a palpal flap. Palpal flap is basically a anteriorly based flap.
So please observe for
So all of you can come here.
Go ahead.
Yes, sir.
So all people should come and see here, you know.
So basically implantation starts with a palpal flap, which is a anteriorly based flap based on the posterior auricular artery. So once you give the posterior incision, elevate the palmar flap, then you expose the cortical bone, then you have to start the drilling. As I have shown in most of the temporal bones, you should start your dissection along the temporal line like this. This should start from here and you have to follow this posteriorly. This drilling should be done with the largest size burr available for that area. You do not use a very small burr. And the dura lies just few millimeter above this line. So you are not going to injure that dura. And like this, you have to draw another line along the posterior canal wall, like Sir has done here. So you have to extend the line towards this. The third line will be a tangential line joining these two lines, like this. And you have to do gradual propagation. Like this, you have to open the antrum. Don't be in a rush to open the antrum, it will come gradually. Like this, you have to subsidize the cavity and you have to accentuate all the mastoid cells. You have to delineate the dura here and posteriorly you have to delineate the sigmoid sinus. That is not always needed for cochlear implantation, but here I am demonstrating it for demonstration purpose. Here you can see this is the sinusoidal angle which is coming into the picture, and gradually you have to subsidize the cavity. You have to go up to the mastoid tip level. You have to go posteriorly a bit. This bone is very now you can see it's vibrating. We'll change the drill bit. A smaller size one. Well, thin out the posterior canal wall, going deep. Now
Hello.
we can see the.
Please note how he is dissecting, how he is delineating the dura. So he is delineating the dural plate. Okay, this is the way you should do the cortical mastoidectomy, because I have not done it completely, but he is doing beautifully. Okay, so to get that access.
And while dissecting in this area, you have to run parallel to the critical structures. Like here in dural plate, to drill like this, not like this. Okay. Here you have to extend this towards the root of the zygoma. Here gradually we will delineate the dural plate. A lot of irrigation system. इसको थोड़ा निकाल देते हैं. Give me a blade. हाँ, ये चलेगा. Tooth force से. We'll remove a bit of soft tissue over here. Now this is not required in a live surgery situation, but in this cadaver you have to remove all these soft tissues before drilling. Okay. Drill. Suction. Well, we are ready to go now. Now you have to delineate the dural plate, you have to delineate the sigmoid sinus. फिर निकल जा रहा है. And here in the mastoid tip cell, there will be the digastric ridge, which is a very good landmark for the facial nerve. Now the sigmoid sinus is picture. थोड़ा लगा दें. Give me a different handpiece, yeah. So the landmark for this exercise is was. We all have done cortical mastectomy in our bones. Now we are going to do it. ड्रिल सर हैंड पीस थोड़ा काम नहीं कर. एक मैराथन का दूसरा हैंड पीस दे दो. ये वाले में करते हैं ना. Well, we are ready with the give me a bigger bulb. फुट पेडल थोड़ा नहीं काम कर रहा है. ठीक है. ठीक है. Okay, we are ready to go now. This bar is wobbling a bit. No problem with that. So here I am delineating the sigmoid sinus plate. इसे एक साइड छोटा लेंगे. And in the process you have to thin out the posterior canal wall. बार थोड़ा छोटा करेंगे. एक साइड स्मॉल. Normally in canal wall down mastectomy we pressurize it up to the limit, but in cochlear implant we leave a ledge of the bone just to support the extra length of the electrode. Now, as we go deep, we have to remove all the mastoid air cells from here. Now, our landmarks for this posterior tympanotomy is the incus fossa infidis superiorly, laterally will be the cauda tympani nerve, and medially will be the facial nerve, a block. So if you have any doubts, you can ask me. किसी को कुछ डाउट है अभी तक तो पूछ सकते हैं. ये हैंड पीस भी अच्छा नहीं चल रहा. I am removing all the mastoid ear cells just to widen the exposure. Suction is not working. Suction not change. ये उतना अच्छा नहीं है, ये वाइब्रेट हो रहा है. हाँ, ये हैंड पीस दूसरा होगा ना, ले आइए. वाइब्रेट कर रहा है. गिव मी अनदर सक्शन. एक सक्शन दे दीजिए ना, एक सक्शन दे दो. हाँ, तब तक इससे करते हैं ना. Okay. So you have to thin out the posterior canal wall like this. This is the tip cells which is coming into view. And you have to saucerize this posterior bony canal wall. This should be very thin so that you could get a vertical access to the round window. Suction is not working. This is the epitympanum. We are drilling towards the anterior epitympanic area. Now once I drill this area, I will be able to see the thought process of incus, body of incus, and the fossa infidis. While doing a posterior tympanotomy approach, you have to be very sure about the location of the facial nerve. I am thinning out the posterior canal wall, and during this procedure, you may damage the posterior canal wall. Sometimes if you go very anterior. If the damage is very less, if the bony canal wall is intact, you can repair it with a bony patty. Or if you have damaged the posterior meatal wall, then you have to repair it with a temporalis fasciae graft. Now we can see the incus is coming into view. Now can you see the incus coming into picture? हाँ. Ball proof dीजिए. Now this is the dome of the lateral semicircular canal. This is the incus, body of the incus. This is the fossa infidis, and this fossa infidis points towards the facial nerve. So it will lie at the level of the lateral semicircular canal, and like this, the vertical segment will come like this. So we are safe to drill lateral to this area. This incus.
Hello, Dr. Pradhan.
Incus buttress.
Dr. Pradhan, Just at this point, please give some tips to avoid facial nerve
Yes, sir.
for the juniors.
Yes. So, if we are following this line, this incus, is it visible, sir? Okay. Suppose we are following this line and we are staying lateral to this line, then we will not damage the facial nerve. We will always be lateral to the facial nerve. And the chorda tympani will run like this, lateral to the facial nerve. So vibrating but can manageable. Now
Yes.
at this level I am thinning as well as I am going deep. One more landmark here will come is the digastric crease. Now I can see we are going anteriorly, slowly and gradually. You should know the landmarks, you should note the location of the facial nerve in the CT scan, and you can measure the distance between the chorda tympani and the facial nerve pre-operatively. Now as I am going anteriorly, I will find a cell just before the opening into the middle ear. That cell is called Herald cell, as I am saying to some of the delegates. Now at this level of the incus, we are going anteriorly. Here you can use cutting burr or diamond burr. Most of the time in live surgical situation, I use diamond burrs. And one more important thing is you have to use copious irrigation while drilling, because the heat may damage the facial nerve. This bone should be peppery thin. And this facial recess approach is used for various purposes, like you can do a cochlear implant, you can do a middle ear implant, and you can approach hypotympanic glomus jugulari, or you can remove cholesteatoma through this approach. The facial recess is widest at the fossa incredis level and it is narrow at the lower level. So it's better to open at the superior limit. The diamond. इसको थोड़ा ऐसे रखना होगा. Okay. Here I have switched over to the diamond burr, and now I am thinning the posterior canal wall. Here you have to identify the facial nerve.
What is the size of diamond burr?
Sorry, sir?
Size of the diamond burr? Size of diamond burr.
Diamond burr, sir, depends on the location you are drilling. You should choose the maximum size of the burr. I think it's a 2 or 3 mm burr. Now I am going close to the Herald cell. Here your direction of drill should be parallel to the critical structures. I know the facial nerve will come somewhere like this. This facial nerve is very vascular, so before damaging the facial nerve, there will be lot of bleeding. Suppose you ignore that, then you will cause damage to the facial nerve. elevator, elevator, elevator. Now we are opening into the middle ear. Elevator, yeah, ball pro. Ball pro, okay. So this is the opening into the middle ear, and we'll widen it to its limits. This could be the facial nerve which is coming into the picture, and we'll follow this. We'll follow into the horizontal segment. One size smaller diamond bar. One size smaller diamond bar. Now I think this is the 2 mm diamond bar. Here I will show you the cauda tympani nerve as well as the facial nerve, so that there will be no doubt where to drill. And through this window we should be able to visualize the round window which we have seen already. Now you can see this is the facial nerve which is coming into the picture. Is it clear? I'll zoom in a bit. Let me go to a higher magnification. Is it better, sir? Is it better? Suction छोटा. Now can you see something running over the floor of the facial recess? This one is the facial nerve. So you have to identify it positively. Now I can thin out the bone superiorly. One size smaller bar. बार एक साइड छोटा दीजिए और सक्शन थोड़ा छोटा कर दीजिए. एक साइज छोटा बर दे दीजिए. एक साइज छोटा बर दीजिए. नहीं, ये इम्प्लांट है. ठीक है, इससे देखते हैं. नहीं मिला है लेकिन सक्शन छोटा. Now I have gone to a smaller size of the diamond bar. Here you can see in the middle ear the glimpse of the round window niche. This is the facial nerve. All you can see.
This is white glimpses of the na.
Sorry, sir.
White glimpse. Jo, this is facial.
Yeah, this is the facial nerve. This is the facial nerve. And we are delineating this. हाँ, एक साइज बढ़ा दीजिए. So sometimes there is a glomus tympanicum lying in the hypotympanum. We may need to sacrifice this cauda tympani nerve and go inferiorly to remove the tumor. You have to remove a ledge of bone over here just to avoid any trauma to the ossicular chain, and this should be done under profuse irrigation.
Dr. Pradhan, what is the superior limit of the posterior tympanotomy? Superior limit of the posterior tympanotomy.
Superior limit will be this bone. This is called incus buttress. The thought process of incus lies over here, and you have to leave a piece of bone over here just to prevent any ossicular damage over here. This is the lateral limit, which is cauda tympani nerve. This is the medial limit, which is the facial nerve, and this is the inferior limit, which will be the caudofacial angle. छोटा सेक्शन दीजिए थोड़ा. थोड़ा हाथ से इसको प्रेस करना पड़ेगा. हाँ, चलेगा. थोड़ा ऐसे रख दीजिए. उनके पास छोटा होगा ना एक. गिव मी अ वास.
Yes, round window niche is visible, na?
Yes, sir. We are visualizing the
Yeah.
round window niche. And you should visualize it properly. You should be able to see the margin of the round window. Round window is basically a vertical structure. The oval window is a horizontal structure, whereas the round window is a vertical structure. So you have to drill the upper lip of the round window or the upper column of the round window to visualize it properly. Smaller section थोड़ा चाहिए. उनके बैग में था एक छोटा सेक्शन चाहिए. सक्शन टिप ये नहीं हो रहा है. Now if you look into the deep, is it visible, sir? Ball Pro, is it visible?
Yeah.
You can see this is the round window upper column, and here you can see the stapedius tendon. This is the stapedius tendon, and this is the upper column of the round window. We are going to drill this area to visualize the round window properly. So there are certain ways of implantation. You can do a cochleostomy, you can go for the round window insertion. Cochleostomy is basically done at the anterior inferior quadrant of the round window. But nowadays most of the surgeons has moved to use the round window insertion. A drill. Here I am drilling the upper column of the round window to visualize it properly. Slow irrigation. Now you can see I am drilling the round window. Our purpose of this drilling is to delineate the round window and define it properly before incising it. And we should get the straight view of the scala tympani where our electrode will be inserted. Now we can see I am drilling the upper column and this round window is coming into the picture. There is a little bit of drilling required at the inferior portion of the mid facial nerve block. Cochlea has basically three chambers. One is scala tympani, one is scala vestibuli, and the third one is what? Scala media. So our insertion should be into the scala tympani. The middle bone, which is a very porous bone which houses the cochlea turns around a porous bone which is called modulus. This modulus houses the neurons of the cochlear nerve. They get transmitted from the organ of Katai through the spiral ganglia and comes through the modulus and forms the cochlear nerve. And the scala tympani is the bigger chamber and it stays close to the modulus. Now you can see the round window is clearly visible. A bit of drilling here and I'll get a straight shot view.
What is the size of burr for cochleostomy?
Size of the burr is around 2 millimeter. As we go deep, we will be using a 1 millimeter or 0.6 millimeter burr. Smaller burr, angled peak. This is the round window membrane. Is it clear to all?
Yeah.
angle peak. Now you can see the round window membrane, angle peak, angle peak, peak नहीं है, ball probe दे दीजिए. Okay, so this is the round window membrane, and in cochlear implantation we have to incise it antero-inferiorly like we do in a laryngotomy. This has to be retracted backwards like this. And you can see the scala tympani. This is the straight pathway into the scala tympani. And in some cases, if the vision is not proper or you are not getting a straight pathway, you can drill this area to get a straight pathway. This is called crista of the round window. Small diamond bar. Now I am excising the complete round window membrane to get a straight shot view. Now you can see the scala tympani clearly. If I zoom in, let me go into the higher magnification. Can you see it clearly?
Yes.
Ball probe. Okay, take. Oh, it's very big. It's very big, sister. Smaller one. Very small, smallest one. सबसे छोटा था? Yes. And here one more tip to prevent facial nerve injury, you should use long slender burrs, long tapering burrs, so that the shaft doesn't touch the facial nerve. Suction block.
अभी कॉक्लियोस्टोमी किए ना.
Here you can see this is the crista of the round window which I am drilling, and now you can see the interior of the scala tympani. This is the interior of the scala tympani. And if I drill over here, sometimes this area is ossified in labyrinthitis ossificans, will not get a proper lumen like this. You have to drill like just inferior to the processus cochleoformis to enter into the middle tongue. So now the scala tympani is perfectly open, so we can go for the insertion. The insertion should be done at a lower magnification so that you can see the implant properly. Now this is the slim straight electrode. You can see plain forceps debe. There are various companies available, there are various types of electrodes available, but the slim electrode is the easiest one to put. You can see this is the electrode. It has 22 electrodes. Can you see, sir? There are 22 electrodes over here. 1, 2, 3, 4 like this. And there are 2 markers over here. This one is the distal marker, this is the proximal marker. This marker should be at the level of the round window for your complete insertion to happen. And this is the handle where I am holding this. Now let's have a look at the round window suction. And while doing the insertion, you have to be very slow and gentle. You should not force it. Now you can see the cochlear implant is going on smoothly. At least you should take at least 1 to 2 minutes while placing the electrode to preserve any kind of residual hearing and not to produce any cochlear trauma. You can visualize how smoothly it is going in. If there is a little bit of resistance, you can remove this and you can reinsert this, but you should not force it. If you force this, then there will be kinking, like what is happening here. Claw है क्या? This electrode is very delicate, so you should not apply any kind of pressure over here. Suppose you are leaving 1-2 electrodes outside, then nothing to worry about. You can leave that in place, but you should not apply pressure. Here I don't have a crocodile forceps. Now it is going smoothly. If you apply pressure over the implant, then it will hit the modulus and it will cause intracochlear trauma. If the resistance is very soft, you can go ahead with the insertion. But if the insertion is very strong, if you are not able to negotiate, then you should remove it and reinsert it. Like here you can see there is some kind of resistance and this electrode is kinking. In this situation you should remove this. In live surgical cases, this should not happen in a live surgical cases. Like this it should go smoothly. Here you can see I am pushing the electrode in, and the second marker should be placed at the level of the round window. Ball proof. After that you have to ball proof. After that you have to seal the round window with soft tissue to prevent any kind of CSF leak. This is the complete insertion into the cochlea. So after that you have to coil this electrode in the mastoid cavity, plain forceps. Like this you have to coil the electrode, extra electrode. As the kid grows, this electrode will lengthen and it will take the shape of the skull. Like this you have to place the electrode. So this cochlear implant insertion is complete. If you want me to show anything more, then I will be doing that. Should we continue or should we go for the lunch?
Okay, stop.
Okay, thank you so much for your attention.
Thank you, Dr. Pradhan, for nice demonstration. Thank you.
इसको थोड़ा ऑफ कर दीजिए.
Thank you so much for the wonderful demonstration, sir. It was a quite learning experience for us. I would request delegate to get back to their seat. If they have their lunch, please be seated at their own station and they can start posterior tympanotomy. And those who have not taken the lunch, please move for the lunch. And once you complete your lunch, please come back to your own table and start dissecting. Your time for dissection will be till 4:30 to 5 p.m. So try to complete as much as part you can. Thank you. Delegates, you can have your lunch. One delegate who had taken their lunch can come back to their own dissecting table and start dissection.
hello, 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 hello.
Check, 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 check.
lateral semicircular canal, and you can see the facial. So get the orientation where exactly you are. So facial is going, this is a mastoid part. Here it will be tympanic part. So this is a mastoid part. So if you go on just thinning it out, yes, if you just go thinning it out, so we can take this facial. So we'll do that, and from here we will take this bone out. Lateral semicircular canal we can open from here. Behind will be the posterior semicircular canal. Okay, I hope the idea is clear. So purposefully I have preserved the ossicles. So for taking out or thinning out the tympanic part, I have to take out the incus. So I will take out the incus. This is the view from the behind cleanly. So get oriented. For that only the posterior canal is been preserved. See this. So here it is the facial. Let's go near. Okay. And you can see the cochleostomy also. This is from the behind. Get oriented. From here I can peep inside. This is the beauty of endoscope. Look at this. I am peeping inside the posterior epitympanum. See this. From here I can see. Come out. Go here. From posterior tympanotomy, posterior tympanotomy, I am just trying to see the cochleostomy. Okay. So come out and now get anatomy from here. So this is how you can master the anatomy endoscopically as well as microscopically. Going from here, here the whole picture is in front of you. You are not going to damage. If you take out the incus, beautifully you can, so अब decompression करेंगे, ठीक है? Clear?
Very nice panoramic view of the middle ear. You can see the malleus, incus,
So we'll take out
stapes,
the incus
round window,
now.
oval window,
चलो
station tube, facial nerve, the course of facial nerve from the mastoid to the tympanic part. Now the sir will remove the incus so that we can have a view of the aortic region.
Forceps. Now the whole facial is in front of you. So now gently we will start taking out that bone from the processus cochleariformis to the second genu to the stylomastoid foramen. सब सामने दिख रहा है? इसको थोड़ा सा कहाँ गया अपना स्टॉर्ज वाला? If we change the modes, you will see the soft tissue beautifully. Stores.
Guys from the stores, please come
because
over
if you
there.
change the modes from Clara to the other, so you can differentiate the soft tissue from the bony tissue. अरे थोड़ा बाद में ये करने के बाद उसको चेंज करो थोड़ा सा हाई कह रहे कहाँ सेटिंग में कैमरा में हाँ ज़्यादा हाँ जस्ट चेंज टू दी अदर मोड उसी के ऊपर हाँ या हाँ हाँ होल्ड ऑन
So we have a panoramic view of the facial nerve showing the right from the process cochleariformis to the stylomastoid foramen.
So this is the spectra A. Little bit of differentiation from the soft tissue. See this. Now the facial is in front of you. It is little bit green view. That is for the soft tissue. Spectra B. So let's delineate little bit more. Little bit thin bone is over the fallopian canal. So we'll do. But can you see this beautiful facial in front of you?
Yes, sir.
Yes.
The complete panoramic view of face.
So now we'll reduce the speed. I will keep the stapes as a landmark. Little bit zooming. So, पाठीमागून पाणी टाकलास तरी चालेल ते. हां, इथून इथून. So just open that, keep a speed low. Flush. Go a little bit near. And you can drill from behind too. Flush. Flush. Yeah. खालून पलीकडून होतं. याला याचाही करतोय मला क्लीन No, this is, we are dissecting the whole mastoid part, okay? So this is here, it will be a stylomastoid foramen which is coming. See this here, huh? This is whole of the mastoid part. This white thing is nothing but a facial. That's better now. Huh? Can you see the course?
Yes, sir.
नजदीक से देखेंगे. Hello.
So now we can see the facial nerve which is exiting from the mastoid part going to the stellomastoid foramen part, exiting from the mastoid cavity. We can clearly delineate the facial nerve right from the temporal part of the facial nerve right up to the sphenopalatine foramen, stellomastoid foramen.
पानी तक That's better now. The whole facial is in front of you. और भी थोड़ा सा जाएंगे नीचे, so that we'll just try to see with the curate. See this curate.
Mubarak sir, please orient us with the anatomy.
हाँ
Please orient us with the anatomy. What you are doing?
पूरा क्या कहते हैं उसको, पूरा सांप पड़ा हुआ है सामने. So like flush करेंगे and sir. That's the whole of the mastoid part of the facial normal saline, and we will get oriented. I have purposefully kept the stapedius and the stapes. Yes, intact. Only the malleus has been taken out. So we will see from above downward, we will track down the facial. वॉश करेंगे। ओरिएंटेशन के लिए हमें पोस्टीरियर कैनाल वॉल भी थोड़ा रखा हुआ है। हाँ, छोटा सा
फेशियल नर्व का पूरा कोर्स विजिबल दिख रहा है।
यस, नाउ विल थोड़ा सा इसको करेंगे, सो पिक्चर विल बी क्रिस्पी। क्लीन करो। फ्रॉम अप विल गो गेट ओरिएंटेड। सो बॉल पॉइंट, anterior wall, posterior wall, inferior wall, superior wall, whole of the mastoid bowl, tegmen, sinus plate, tip. Okay, yeah. So this is a lateral semicircular canal. So we will first go from behind. Dr. Pradhan has done that posterior tympanotomy, but I have widened it for the access to this here. So let's go from behind. This is a picture from the behind. I am in a mastoid. Now the inner mastoid, this is mastoid's anterior wall, means the posterior canal wall. This is a superior wall, that's a tegmen. This is a sinus plate. This bulge is nothing but the lateral semicircular canal. Antrum. This is a posterior epitympanotomy. This is the head of the malleus. We will go near and see. This was the small part of remaining posterior incudal ligament. Here the short process of incus was there. There's posterior incudal ligament, and then there is a superior incudal ligament by which the incus is hanged inside. Okay, so we will go near, and here from this distance, see, I am keeping the endoscope quite away, and from here you can still judge. This is what I have said in the morning. Step is 3 mm posterior superior. Without, if you don't see also, there has to be a tympanic part of facial nerve. So there is a tympanic part of facial nerve is this. Okay, we will go near and see. 3 mm posterior superior to it, lateral semicircular canal. If you see the lateral semicircular canal, make 3 mm anterior inferior facial. 3 mm anterior inferior, step in. So one landmark is there, you will not miss the other, you will be able to find out. So now I will go very near from behind. We will give the angle. This picture is from the behind. Canal wall is there. This is a widened posterior tympanotomy. Okay, and from there I am trying to see. So now get oriented again. Keep the landmark. Your malleus is there. Your stapes is there. So from there, stapes, tympanic part of the facial nerve, whole of the mastoid part, lateral semicircular canal. We'll go near. Yes, that much we are going to try to see from here. So this is the tympanic part, okay? From here, we have to just little bit drill here. You can see the crus, anterior crus, posterior crus, right? Let's get oriented more. From here, this is what? Yes, tendon. From here, see, this is a superior malleolar ligament angle. This is from the behind. Okay, get oriented. Superior malleolar ligament. This one. We will just, I am going to take it out, okay? Malleus from here. Keep an eye. Tensor tendon. This is nothing but a cog. So this is the bone which is separating the anterior epitympanum from posterior epitympanum. And here there is a one fold. So let's go, let's keep this. And when you put here, you will come through this series. tensor fold. Okay, this is gone here. So let's take this out. We are seeing from behind. Now let's go from front. Give me the forceps. Can you see the beautiful course of facial?
Yes.
So now we will open the geniculate ganglion also, and we'll go to find out the labyrinthine part. करना है? No oxygen. Okay, चलो.
ऑक्सीजन लेना
हाँ नहीं करेंगे पहले. Yes. So see the rest everything second genu you can see. Tympanic part. I love going to mass parties. I intracranial. Love. Labyrinthine. Going. Geniculate. 2. Tympanic.
And then
Mast. Mastoid. Parties. Parotid. भूलना नहीं. Yes. So coming from here, I am coming from behind. So now we'll try to drill here. This is a part of geniculate ganglion. So the landmark of processes cochleariformis. Lot many changes happen at the posterior cochleariformis process. One, that's tensor tendon gets inserted to the neck of the malleus. The Jacobson nerve goes there and gets, that's a rough, but from the geniculate ganglion, greater petrosal nerve takes an origin, goes into the anterior canaliculus. Okay, and here from the geniculate ganglion, the facial turns and becomes a labyrinthine part, and then intracranial part. Okay, so let's try to drill that. Yeah, here. Oh, good question. See, yes, इसको छोटा drill लेके उड़ा दे, कोई problem नहीं. That's tympanic neurectomy. उसको तो disrupt करना है. Even if you use a bipolar there, जला दे उसको, कोई problem है. Neurectomy हो गया. Okay? This one, can you see this? नजदीक जाके देखेंगे. दिखा क्या? Jacobson. That is a Jacobson. उसको कट मारा. This one. उसके ऊपर कैनाल है अभी. Many of the time it's open. इसको कैनाल है. तो ड्रिल कर दे, उड़ा दे उसको, हो गया tympanic neurectomy. रफ में, ठीक है? So see, so beautifully the tympanic part is seen.
Yes, sir.
अभी geniculate ganglion का निकालेंगे. So it is going and turning there. थोड़ा सा ड्रिल करके इसको रिलोकेट कर दो, हो गया. वैसे मैंने डिकम्प्रेस कर दिया इसको. एकदम कम वाला स्पीड. स्टेपीज को रखेंगे. नहीं. This is nothing but a part of the scrotum. So this is a processus cochleariformis tensor tendon. Just opposite to that is a cog, the bone which is separating the anterior epitympanum from posterior epitympanum. Yes. And the fold going from here to the anterior wall, that's nothing but a tensor fold. Okay, which is separating the supratubal races from the anterior epitympanum. This is nothing but a canal for tensor. Okay, this is a canal for tensor. This is eustachian tube. Anything above the canal for tensor is supratubal races.
Sir, just a second.
Yeah.
So there is an announcement. There is a first prize for the best dissector. So dissect it carefully. Who will delineate all the canals, who will delineate the facial nerve course, he'll get the prize. So don't leave your bone, dissect it properly, then go.
Yes, yes, this is a steppies. Steppies is there. Steppies I have kept as a landmark. Okay, this is a steppies. This has become mobile due to the cochleostomy. Okay. Yes. Flush. Talker. Ball point है ना ball point. Now this part has gone, okay? This much. This from the geniculate. See, this is a geniculate. This part is जस्ट गॉन. ओके, सो यहाँ से यहाँ तक का फेशियल नहीं है, निकल गया है. सो फ्रॉम हियर दिस इज अ टिम्पैनिक पार्ट, so I am just elevating from here. See this. Okay. इसके लिए ओके, पीछे आ जाओ. वहाँ का उतना पार्ट जो जेनिकुलेट से उधर से कट हो गया है वो. हाँ, so now from here नीचे तक और ड्रिल मार के उसको उठा सकते हैं. ओके, यहाँ से थोड़ा सा बोन है, इसको हटा देंगे, आ जाएगा, पूरा निकलेगा. स्क्यूरेट. हो गया मेरा,
हो गया.
अभी थोड़ा सा और थोड़ा सा स्टाइलो मास्टर को निकाल के पूरा निकाल के हाथ में दे देंगे फेशियल आपके.
लेके जाता है, लगा देना है.
तो
5-5:30 तक अपने कर ले
चलेगा. या
7 बजे अपना वो बच्चों को आने का.
बिल्कुल बिल्कुल.
डिनर के लिए, है ना?
यस.
एक बार अनाउंस कर दो 5 बजे का टाइम.
यस, क्लीन.
क्या सर,
नो,
आपके परमिशन?
कोई प्रॉब्लम नहीं, आप है.
5 बजे का टाइम देते हैं इन लोगों को, 5:30 लेके वाइंड अप कर.
यस,
So that by 7 please arrange for the inaugural.
राइट.
ठीक है ना?
यस.
एक बार अनाउंस कर.
Thank you, sir, for the wonderful demonstration of the facial nerve. And today's session will close by 5 p.m. We have a inaugural function at the Crystal Palace from 7 p.m. So all the delegates are requested to come there by 7, and it is followed by the family dinner. So all of you are requested to finish off your temporal bone dissection, and whatever is left, you will be allowed to do it tomorrow morning, which will be followed by the live endoscopic ear surgery by sir, which will be relayed from JLMCH, Department of ENT.
हाँ, नहीं इतना है तो डैमेज तो नहीं होगा, उसको ग्राफ लगाना पड़ेगा लैबिरिंथाइन में. यूजुअली नहीं है तो 3 मिलीमीटर का ग्राफ बीच में लगाना पड़ेगा. नहीं तो उठा के सिर्फ टेम्पोरली स्पेशल रोल करेंगे तो भी बढ़.
क्या हुआ होगा सर? हॉरिजॉन्टल हॉरिजॉन्टल पार्ट में कितना सागर होती है?
हाँ, इसको
क्या मतलब
क्या किया था?
मतलब वही सर कैनाल वाल डाउन किए थे, तो पता नहीं
कब किया है?
15-20 डेज.
और बाकी कुछ कार्टिलेज वगैरह डाला है?
हाँ, वो तो
हाँ कार्टिलेज का क्या ग्राफ डाला है ना, तो अगर पता हाँ डाला फुट प्लेट पे ओनली इफ द फेशियल इज एक्सपोज एंड ये है तो प्रेशर रहेगा, रिकवरी है तो उसको स्टेरॉइड दो, बिकॉज इफ देर इज अ माइल्ड डैमेज देन इट विल रिकवर।
इसका मतलब क्या पैरालिसिस है?
तो पैरालिसिस है, आप कितना बंद हो रहा है पूरा, हाँ ये रिकवर हो जाएगा, रिकवर हो जाएगा। इसको क्या दे रहे हो आप?
पहले तो इंजेक्शन
नहीं सर पूरा स्टेरॉइड अच्छे से दे देना, 6 मिलीग्राम TDS डेप्लोजोफॉल, हाँ बाकी कम से 10-15 दिन दे देना उसको, हाँ तो फिर हो जाएगा उसका रिकवर। और मेथिल कोबालामिन 1500 मिलीग्राम उसको ले सकते, हाँ हो जाएगा, होगा वो, उसको थोड़ा देर लगेगा, बट इट विल टेक अनदर, इवन इट कुड इफ इट इज फॉर फाइबर विच आर डैमेज दिस विल टेक अनदर 3 months also. But eye closure is there, good. That is a good thing. So हो जाएगा, हो गया? हाँ तो अगर वो छोटा सा है 1 मिलीमीटर का डैमेज तो भर जाता है, ज़्यादा है तो थोड़ा सा प्रॉब्लम। छोटा थोड़ा That's a lateral semicircular canal. Okay? 3 मिलीमीटर जो बोला ना, हाँ यस दिखा क्या? थोड़ा सा फेशियल और इधर थोड़ा सा निकाल देंगे और नीचे, हाँ तो कोर्स पता चलेगा। हाँ ये तक मोस्टली उधर हो जाता है इधर
तो फॉरवर्ड
हाँ ले तो यहाँ से चला गया। दिस इज अ स्टाइलोमास्टाइड। ओके, ये जो जा रहा है, हाँ ठीक है, छोड़ देते हैं अभी इसको। उस चीज़ को ऊपर और ड्रिल करना पड़ेगा। हाँ? थोड़ा कॉकलिया को सिर्फ दिखाई नहीं दिख रहा, कॉकलिया कुछ थोड़ा सा स्लो कर, स्पीड 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 कम कर। Flush. Oxical होगा सिकल तो हे होता ना तो बघू नाही हे अडकतोय कुठेतरी वाढ am just trying to see subcochlear. ये कोई सर्जिकल एक्सरसाइज में नहीं है, बट अगर होता है का ये मैंने कॉक्लिया का ओपन कर दिया है जस्ट टू सी. Yeah. नहीं, this is I am drilling the hypotympanum. Yeah. क्लीन करा Tickle. This step is both the crux ये ले लेना स्टेशन ट्यूब देख लेंगे थोड़ा फारत लाम लावलास लग मजा मत कर पोच ना काय मोटर एंडोस्कोप और एंडोस्कोप किती वाजले किती फ्लैट नाइफ ये कुछ नहीं, मैंने ज़रा सब कॉक्लियर अप्रोच के लिए पूरा देखा स्पेस कितना है, तो दिस इज हाइपर सब कॉक्लियर के लिए। हाँ नहीं, ऑफर दैट अगर पेट्रस एपेक्स के लिए क्या लेना बॉल पॉइंट बॉल पॉइंट Eustachian tube, supratubal race. So this bony plate is for the separating the carotid. This one. This bony plate is behind this. There will be the carotid. Eustachian tube. This is a labyrinthine part of the facial. के बीच में कट गया है। हाँ, this is a labyrinthine part of the facial. Yes. इसको आगे इसको yes. So it's going like this. It's covered. It's covered. So ये पूरा tympanic part, mastoid part, stylomastoid here, and we will call for the day. कितना टाइम हो गया? 5 हो गया। Bone, fallopian canal. That is called. बहुत there is 1% chance है, तो वो डायरेक्ट दिखेगा पॉपिंग करते हुए। हाँ, रहेगा बहुत रहेगा।